Hello and welcome to Advanced Cardiac Life Support Part 1. This is the first module in a three-part series covering the essentials of ACLS for senior critical care nursing students. In the first module, we will cover the basics of what ACLS is, a review of BLS, and then an overview of what you will learn in modules 2 and 3. Now let's get started. Advanced Cardiac Life Support, or ACLS for short, is a specialized training program designed to equip healthcare providers with the knowledge and skills necessary to manage cardiac emergencies and other life-threatening situations. ACLS builds upon the foundation of basic life support, or BLS, by focusing on the advanced interventions that can significantly improve patient outcomes. This course will take you through the basics to more complex life-saving techniques. Now, many of you guys have already taken a BLS course, and so what we're going to be doing is reviewing that BLS in the beginning, making sure that you know those foundational pieces, and then building upon it. ACLS is particularly important in critical care settings, such as the emergency department, in the ICU, in a cardiac cath lab. Those are just some examples. It equips healthcare providers with the ability to respond quickly and effectively to cardiac arrest, stroke, respiratory distress, and other critical care conditions. The interventions taught in ACLS are evidence-based and have been shown to increase the chances of survival and improve patient outcomes. Now, notice that I said healthcare providers. ACLS is not just for nurses. ACLS is often taken by even medical providers, paramedics. It is most often typically used by nurses, but there are other providers that do and are certified in ACLS. So a little bit about the journey from BLS to ACLS. Basic life support, or BLS, is the cornerstone of resuscitation. It focuses on the ABCs of the airway, breathing, and circulation. It provides the fundamental skills necessary for saving lives. ACLS builds upon this foundation by introducing advanced techniques such as defibrillation, advanced airway management, and administration of medications. When you transition from BLS to ACLS, it involves expanding your knowledge, developing critical thinking skills, and mastering complex algorithms that are essential to save lives. So basic life support is the foundation of resuscitation. It focuses on the immediate response to cardiac arrest and other life-threatening emergencies. It ensures that oxygen is delivered to all the vital organs like the brain, the heart, the lungs. BLS emphasizes the importance of high-quality chest compressions, proper ventilation, and early defibrillation, all of which are critical to maintaining circulation and improving the chances of survival until an advanced care team and advanced care can be provided. BLS, the ABCs of airway, breathing, and circulation, serve as a systemic approach to assessing and managing a patient's condition. The airway must be clear and open to allow for effective breathing. Remember that, no airway, doesn't even matter about those other things, right? Airway first. Breathing should be assessed to ensure adequate oxygenation and ventilation. Circulation is evaluated by checking for a pulse, and if none of that is present, you initiate chest compressions immediately. You don't wait. This approach ensures that the most critical aspects of resuscitation are addressed very quickly and promptly. The chain of survival is a critical concept in BLS. If you guys have already seen this, you can look at this picture right here and you can follow on it. Now, this has a couple of pieces that are in addition, but go with me here. These steps are designed to maximize the chance of survival and are foundational to effective resuscitation. The first link in the chain is early recognition and activation of the emergency response system. So remember that BLS, you can activate it in the normal world, like out on the street, in a shopping center or anything, but you can also do it as well in a hospital setting. So activating the emergency response system in, the world is calling 911 versus, calling a code blue in the hospital. So it's it's really important and it's vital to identify the signs of cardiac arrest quickly and to call emergency assistance without delay. Recognizing that the emergency and summoning help immediately can make one of the most significant differences in patient outcomes. The second link in the chain is immediate and high-quality CPR. Upon recognizing that the heart stopped and cardiac arrest has occurred, chest compressions should be initiated very quickly, immediately. High-quality CPR with the correct rhythm, depth, technique, all those things is crucial to maintaining circulation and getting oxygen around to the body until more advanced care can be provided. The third link is rapid defibrillation. So we all know that you don't always have an AED right on your side when somebody suddenly has a cardiac arrest. So hopefully that AED, external AED, gets there quickly, okay? The use of that AED as soon as possible is key to restoring a normal heart rhythm in case of ventricular fibrillation or pulseless VTAC. The AED will guide you through the process. It gives you like those on-screen, not on-screen, I'm sorry. It gives you audio like prompts to like let you know that it's analyzing the heart, and it kind of does all the thinking for you. The final link for the advanced life support and post-resuscitation care, once you've done the BLS steps and everything's been performed, the focus is going to now shift on the advanced interventions, such as those taught in this course in ACLS. This might include, like we've said before, advanced airway management, medications, continued monitoring, stabilization of the patient, and all these things are put together to help improve the chances of a patient recovering. So by understanding and following this chain of survival, you play a vital role in providing life-saving care during a cardiac emergency. Each link in the chain is important, and together they form a comprehensive approach to managing critical situations that you might encounter. So why a strong BLS foundation is essential for ACLS? We've kind of mentioned it before, but a strong foundation is important for the success in ACLS because it forms just that basics for the advanced interventions. ACLS builds on those skills that you learned in the BLS course, requiring a solid understanding of basic resuscitation principles. But with this foundation, healthcare providers may struggle to effectively perform advanced interventions and make critical decisions during like a high stress situation. Ultimately, that will impact patient outcomes. So, kind of a review of BLS. If you aren't in the hospital setting, but even if you are, you should always make sure the scene is safe before you go in. So there's a picture on your screen of a car accident. And I know a lot of nurses and nursing students, they feel the need to respond, but you don't want to become a patient yourself. And you may think that this may only happen in the outside world, but this can happen in the hospital as well. You could have an electrocution in the hospital. There could have been water on the floor and an electrical line is touching it. So always just a quick scan of the scene before you immediately jump into action, okay? So ensure that the scene safety is ensuring that the scene is safe is crucial and critical in the emergency response. Before you approach that patient, healthcare providers must assess the scene for potential hazards and take appropriate precautions. This includes identifying dangers such as traffic, fire, or even violence. And that's a big one that might be occurring in the hospital setting as well. And then you need to take the steps to mitigate those risks, lower those risks. And it might mean you have to step back and wait, okay? But you need to assess the scene first before you just immediately start intervening. So, activating the emergency response. So your patient's coding, you want help. We want as many hands on deck as we can, okay? So in the hospital setting, you're going to be activating that code blue. If you can't reach a code blue, you're going to physically yell for help, okay? You're going to do what it takes to get people in the room so then they can then activate the code blue button, the pull tab, however the facility is that you're working at manages that. Obviously, out in the real world, you'd be calling 911. So immediate activation of the emergency response system is another crucial step in a cardiac emergency. Calling for help as soon as possible ensures that additional resources, such as advanced life support people with ACLS, and the equipment that you need are available as quickly as possible. Early activation is the first link in the chain of survival, and it significantly improves the chances for a positive outcome by setting the stage for subsequent interventions like CPR and defibrillation. So the chain of survival highlights the sequence of actions necessary to improve survival rates in cardiac emergencies. Early activation of the emergency response system is the first and critical link in the chain, ensuring that a timely intervention such as CPR, defibrillation, and advanced cardiac care can be initiated. By calling for help early, you set the stage for coordinated and timely response to the emergency. I know that oftentimes people, nurses, get stressed and in the moment, and you don't know what to do, and you think, I need to start compressions. That's what I need to do. But calling for help and then starting compressions is the better choice. You need those hands because you cannot keep doing compressions forever. Trust me, you get very exhausted very quickly if you've never done that. And you're going to have to stop compressions if you've already started them to go and activate the call blue button, the code blue button. Okay. So, and we all know that every time you stop chest compressions, that lowers survival rates. So now let's talk about CPR. High quality CPR is a fundamental component of both BLS and ACLS. It involves delivering effective chest compressions and providing adequate ventilation to maintain oxygenation. The key element of high quality CPR includes maintaining the correct rhythm and depth of the chest compressions, allowing for full chest recoil and ensuring proper technique for the rescue breaths. High quality CPR is critical in keeping the patient's blood circulating until more advanced interventions can be applied. So the whole purpose of this is we are going to manually keep the pump going so that what is in the system can keep flowing. We can get what little oxygen is in there to all of the brain, the lungs, everything that we can, okay? That's the goal. The rhythm and depth of effective chest compressions. Now, so there's some numbers on the screen that are going to be, they should be familiar, but maybe you've forgotten recently because you haven't taken BLS in a while. So let's go over them, okay? So the compression rate, that's how fast we're actually pushing on the chest, okay? For BLS, initial CPR, the compression rate is 100 to 100 compressions per minute. And I will tell you that often in the focus of things and the craziness of the situation, often people will start out fast and then they slow down. And it's not always because that they're getting exhausted. It's because more things are happening in the room, especially in the hospital, and they become distracted and they don't keep focusing on the rate, the depth, the rhythm, and all that kind of thing. So if you are on chest compressions, if that is your job, that is your role, just basically tunnel vision, and you focus on making sure that you are pumping on that chest as fast as you have to, okay? So the recommendation is 100 to 120 per minute, okay? And there's obviously a couple songs to remember that. We'll go over that in a second. And the depth for adults, it's at least 2 inches, okay? Children, so this is like age 1 to puberty, it's about 2 inches or a third of the depth of the chest because, as y'all know, a 1-year-old and an 8-year-old, different size thoracic cages. So a good rule of thumb, what I just always try to remember is a third of the depth of the chest for anybody that's like preteen or younger. That's just kind of in my head. Okay, but infants, that first year of life, it's about 1.5 inches. So it's not nearly as deep as adults, okay? And you want to maintain a consistent rhythm. You don't want to go boom, 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 boom. It needs to be dun, 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 like consistency, okay? So now the importance of allowing full chest recoil. What that means is that when you push down all the way, you are allowing that chest to completely recoil and go all the way back up, okay? Full chest recoil is an essential component of high quality CPR. After each compression, the chest should fully recoil to its natural position, allowing the heart to refill with blood, and it will improve subsequent compressions, okay? So to achieve this, it's important to avoid leaning on the chest between compressions, like kind of putting your weight into it, like the weight of your upper body. Now you're going to be pushing on the chest with your strength, but you're not putting your weight into the body. Okay, so ensuring that full chest recoil, it optimizes the blood flow and it enhances all the chances of the patient having a positive outcome. Okay, now we also need to talk about hand placement. For adults, you're going to place the heel of one hand on the chest, on the lower half of the sternum, and then the other hand is going to go on top of that, and you're going to interlock your fingers. Okay, so hand on top of each other. And there's kind of a picture right there for you to kind of see for the adult hand placement. Children, age 1 to puberty, it's 1 or 2 hands depending on the size of a child. And I will tell you, it's kind of like the 5-6-year-old range and below, 1 hand. When they kind of get more preteen-ish, you're going to probably need to do 2 hands. And if you do one or the other, if you realize you're with 2 hands, you're just going way too deep, then switch back to 1. But if you're on 1 and you realize you're not able to truly push down strong enough to get that 2 inches or wherever, that third of the depth of the chest, then you need to switch to 2, if that makes sense. But that first year of life infants, we're going to be using the 2 fingers placed just below the nipple line in the center of the chest. So it's kind of on the sternum, but it's a little bit below, okay? So it's on the sternum, not below. But remember the proper hand placement. So the proper technique for rescue breaths, okay? So the biggest thing is we want to see that chest rise. We want to see a visible chest rise. It's like you're blowing up a balloon, right? The lungs are a balloon. So in addition to the chest compressions that we just spoke about, rescue breaths are just as important of CPR. The proper technique for those rescue breaths involves delivering breaths that are sufficient enough to actually make the whole chest rise, and you can visibly see the chest rise and fall. For adults, 1 rescue breath should be delivered every 6 to 8 seconds, okay? That then responds out to, and here we'll kind of go over the compression to ventilation ratio. Effective ventilation is crucial to maintain oxygenation during resuscitation efforts, ensuring that vital organs receive the oxygen that they need, okay? So what the AHA recommends is adults age 8 and older, when you have 1 or 2 responders, whether it's just you by yourself or you have a partner with you, it's 30 compressions to 2 breaths, okay? So when we get the bag valve mask, that's the more 6 to 8 seconds. So it's, you squeeze the bag, and you wait a couple of seconds, 6-ish seconds, and then you will squeeze the bag again. But when you're actually manually doing ventilations, like you're breathing, like on the lower picture there on the bottom, it's 2 breaths for every 30. Okay. Now the pediatrics, infants up to age 8, it's a little different, and you need to remember this. So if it's just you by yourself, it's the same as adults. But the difference is that when you have 2 responders, it's now 15 compressions to 2. Okay. So remember those numbers. That's really important, especially if you're dealing with 2 rescuers and a pediatric patient. So practicing the rhythm. Okay. Remember what the speed was? 100 to 120 per minute. So this is a video, if you can see right here on the screen. And, there's many songs, and one of those is Staying Alive. So you can sing that song to yourself, or you can tap your hand right here. So that's about the rate that you want to go. And you can sing it in your head. Please don't sing it out loud in real life. There are other songs that people sing, but it kind of has that fast beat. Okay, typically it's songs that you could go running to, that 100 beats a minute kind of thing. Those are good songs. So you may have your own song in your head, or you might just be doing the Staying Alive. Okay, so I suggest you do get a song and you sing it to yourself in your head, because like I said, a lot of times so much stuff's going on and people will start slowing down, and because they're not focusing on the rate in which they are compressing the chest. And when you're singing the song, it's kind of easier to kind of keep that rate going the right way. So now let's talk about the automatic external defibrillators. So these you will see out, we even have one by our elevators down first floor. I believe it's every floor, but there's an AED right there by the staircase in the elevators. These are all over the place. I think they're wonderful. I cannot believe that we lived in a day before they existed. But automatic external defibrillators, we also call them AEDs, are portable devices that deliver an electric shock to restore the normal heart rhythm in case of cardiac arrest. AEDs are designed to be used for both healthcare professionals and lay people, providing voice prompts to guide them through the process. And that's the important part. Anybody can use these things because it tells you exactly what to do, right? Understanding how to use them, though, is very important in effective defibrillation, and it improves the survival rates in cardiac emergencies. So you can see here on the picture, this is obviously a training program, but they have sticky pads. The sticky pads have pictures, tells everybody exactly where to do. You just turn it on. If y'all remember from BLS class, as soon as you get the AED, what's the first thing you're supposed to do? Not put the pads on the person, turn it on, right? Because it's going to take a minute for it to turn on and charge up. So turn it on while you're still placing the pads on the person. So the role of so the one that we have looks more like this. It's in a lockbox, right, in the C-ship building. So the role of the AED in improving survival rates, it basically plays, it's what I've already said, it plays a crucial role in improving survival rates in cases of cardiac arrest. They allow for rapid defibrillation, which is essential in restoring that normal heart rhythm. AEDs are designed to be user-friendly, provide those voice prompts, and readily available to ensure healthcare providers and any lay people that are trained can use them quickly in an emergency. I want you to know, I know we're going to go into this later when we go into the actual shocks delivered in the ACLS component. But when the AED says shock advised or shock not advised, that is there electricity going through the heart? Okay. If it detects that there is electrical current going through the heart, so the heart is doing something on its own. It may not be fully squeezing or maybe like quivering or basically spazzing out. And when it does that, it can't completely squeeze all the blood out everywhere. And so that's why you might go pulseless and not get enough oxygen to your brain. So then you become, like loss of consciousness and that kind of thing. But the heart still kind of has some electrical activity. Basically, what the AED is doing is it's shocking it. It's basically turning the computer off and rebooting it. Okay. But here's the deal. If your computer's like spazzing out and it's like the screens are going all over the place, but there's electricity in there, turning it off and turning it back on really quick may fix it, right? But if you go up to your computer and there's no electricity running through it at all, it has no charge on it, what good is turning it on and off going to do? It won't do anything. So that's the same concept for shocking. If it's asystole, there is no electrical activity going through there. It doesn't matter if you send a shock through it or not. It's not going to reboot the system. So you just need to do compressions. So that's just something for you to, like a little nugget to tuck away. If you didn't already know it, you might have already known it. That's great. But we cannot shock asystole. So an AED is not going to shock a heart doesn't have any electrical activity in it. Okay. So ensuring the safety during defibrillation, big important thing, right? We want to make sure everybody's staying away. We don't want them shocked. Now this picture isn't an AED. It's somebody with the paddles, like old school style, shocking a patient. But we want to make sure that nobody's touching the patient. Nothing's touching the patient. We want to make sure the patient's not on a wet surface because electricity can travel through water. Remember that. You just want to make sure everybody's safe before you deliver that shock, before you push that button on an AED. So now we're going to kind of start talking about transitioning to ACLS. ACLS represents an advanced form of BLS, and it requires transition from the thought process of just a basic response, do these steps, to more advanced care and a lot more critical thinking. It involves a more complex, nuanced approach to resuscitation. It requires healthcare providers to develop critical thinking skills and to really memorize those algorithms that go with the different patient presentations for ACLS. When you transition to ACLS, it involves expanding your knowledge, refining your skills, and embracing the challenges of managing serious medical emergencies. So, like I just said, it builds upon the foundation of the BLS, and it represents an advanced form of care. Now, you see a picture here. These are more paramedics looking like they're responding on the scene. Paramedics are great at ACLS. In fact, all paramedics are better at ACLS than most nurses because most nurses aren't necessarily ACLS trained. ICU nurses, ER nurses, OR nurses, PACU nurses, they are definitely ACLS trained, but other areas of nursing, they may not see codes as often. And so that's why they may not require ACLS, but I guarantee you all paramedics are. So, so this is it's a team approach. ACLS, you can start it technically on your own, but it's really looking at team dynamics that you have at least 2 people present to be doing multiple things at once for that patient to improve care. So to prepare for a deeper dive into ACLS, it's important that we're going to talk about and emphasize the need for focused study and practice. There are algorithms. They will be posted in the online session. You need to read through them and become familiar with them. Understanding that ACLS requires more than just knowledge, basic, like memorizing the steps, like this algorithm that's on the screen. It involves you have to not only know these algorithms, but you also need to know the medications, rhythm interpretations, and also be able to make some critical thinking decision skills on the fly. Developing an approach to patient assessment and management will also prepare you to handle the complexities of ACLS. And the goal is for you guys to be confident and to know what to do. By investing your time and efforts now as a nursing student, hopefully you'll be better prepared whenever you graduate and you go off into the real world and start working. Now, the algorithm on your screen right here, this is for cardiac arrest. There are other algorithms, like I said, and it's just kind of begin CPR, and you can kind of follow it. Yes, no, do this, that blank, blank. CPR every 2 minutes, epinephrine every 3 to 5. This is where it gets so important that you have a team, because how can one person remember all this? Every 3 minutes, every 2 minutes, every 1 minute. There's so many things. Don't worry about memorizing this right now in this presentation. Afterwards, go and look at these algorithms and become familiar with them. So what is ACLS in a nutshell? Okay, it is a specialized training program, and it's designed technically, ACLS is provided by multiple organizations, but the gold standard is the American Heart Association. And I guarantee you, almost all facilities require AHA ACLS. They're not going to take a certification from a third-party company. Okay, so obviously, I'm not AHA right now and giving you this presentation, so this you will not be able to get a card. But my goal would be that if you go through this, you can just ace your ACLS class if you wanted to go and take it and become certified. And yes, as students, you could go and take ACLS. So just something to think about. Okay, so ACLS, it builds on those foundations of BLS like we already talked about, okay? The goal is enhanced patient outcomes by doing more interventions that will lead to better patient outcomes, okay? And it's improving those post-resuscitation care. Okay, so it kind of takes it beyond just you're just doing CPR managing airway, like it's the what is next. That is ACLS. Okay, so some definitions and objectives of ACLS. The primary objective of ACLS, remember, we're moving from BLS, where the objective was just to keep oxygen getting to those organs. The primary objective to ACLS is to restore and maintain a patient's circulation and oxygenation during cardiac emergencies. So that's that restore, whereas BLS was just maintaining oxygen. Now the goal here is to restore it where we don't have to mechanically do things anymore, right? The goal is to get the patient to breathe on their own, their heart to beat on their own, that kind of thing, right? So the protocols that we use in ACLS are all evidence-based, and they provide a structured approach to guide healthcare providers in making those critical decisions. The ultimate goal is to achieve what we call ROSC, and that's ROSC, and that stands for return of spontaneous circulation, or in other words, the heart starts beating again. And you're going to hear people, did they get ROSC? Did the patient got ROSC 3 minutes ago? You will hear people use that terminology, and what that just means is their heart's beating on their own. We don't have to mechanically do it for them anymore, okay? Now, if a patient achieves ROSC, that improves, obviously, their chances of recovery and survival dramatically. Could they lose circulation again? You betcha, but that's why you keep monitoring them. But yes, obviously, ACLS goal is that they're breathing on their own and their heart is beating on their own. So ACLS, the one other way you can think of it is it's like a toolkit that providers have, a toolkit of knowledge and also equipment and also people to help you when there's a serious medical emergency, okay? It provides healthcare providers with comprehensive toolkit for managing serious medical emergencies. It includes advanced airway management techniques such as endotracheal intubation, as well as the use of defibrillation or synchronized cardioversion. Those are different things, and we will learn about those later. And those are all to treat life-threatening arrhythmias. Arrhythmias meaning that the heart is still beating, but not necessarily beating in a way that will sustain life, right? Additionally, ACLS covers administration of those critical care medications and the interpretation of cardiac rhythms. So brush up on, dust off those EKG skills. Mastering these skills will help and enable you as a healthcare provider and as a nurse to respond effectively to all sorts of cardiac emergencies that could come your way that you may be exposed to, okay? From cardiac arrest to strokes. So again, the primary goal of ACLS is to achieve a return of spontaneous circulation, also known as ROSC, okay? And once that ROSC is achieved, the focus is then going to shift on stabilizing the patient's vital signs and addressing the underlying causes of the emergency. The interventions that we do at that point are specific because the goal at that point is to improve the patient outcomes and increase the chance of long-term survival, not just like in the moment, like we want them to go on and be able to walk out the door of the hospital, okay? So after we get the heart beating again on its own, maybe the patient's breathing or not on their own, they're probably intubated, but their heart is at least beating on their own. We're not having to physically pump on the chest, right? What we need to do is now you're going to hear it as called H's and T's, and we'll go more over this in a later module. But those H's and T's, they're the things that cause the heart to stop beating in the first place. Because if it did it before, it could do it again, and we want to make sure we're treating those things. It might be an electrolyte imbalance. It might be a blocked artery in the heart or something like that. This where we need to go to the cath lab immediately to restore blood flow to that part of the heart to get it where it doesn't die and it keeps beating. So we have to kind of go through these things very fast, very rapidly. And I guarantee you, your brain is already thinking about these things as soon as you start CPR. A really good, experienced nurse and provider, they are already going through H's and T's because, like in real life, all this stuff is happening all at once. But as soon as ROSC happens, we want to start thinking about what caused it, and we need to make sure that we're preventing this from happening again. Okay, so a little comparison just to kind of recap and review the differences between BLS and ACLS. You need to understand the difference. Okay, so BLS is the immediate response to cardiac arrest, with the goal being, let's just keep the heart pumping and the oxygen flowing to those organs. We're just kind of maintaining this, but there's no like final on that point. Yes, you can call time of death at that point, but we're going to go into ACLS before we do that, right? So ACLS is those advanced interventions for circulation and oxygenation with the goal of the heart beating on its own again, okay? So where we don't have to do compressions. Now, we might breathe for them. They might breathe on their own. That's neither here nor there. But the goal is that the heart is beating on its own, okay? And so with that, looking at these things, this is, you might want to, zoom in or not on this picture, but so basic life support, the audience for that, it's lay people, but also healthcare people, versus ACLS is going to be healthcare providers such as physicians, nurses, and paramedics. Okay, so the training of BLS, it's covering just those basic life skills, just CPR and AED, and it also includes choking. But the training of ACLS addresses those advanced airway techniques, those meds, and all the cardiovascular pharmacology. So you have to have that higher education to be able to even apply ACLS stuff, right? So to go and take BLS, there's no prerequisites. Anybody can go and take BLS. But to take ACLS, you have to have BLS first, and you have to have some basic understanding of ECG interpretation and basic med understanding. You don't have time to truly learn those in the course, so you kind of need to know them before the course. Then the other comparison is BLS is just a couple hours, whereas the full ACLS course is often, the initial one is often a 2-day, full-day course, okay? The renewal, which is the same, so they both renew every 2 years. The renewal for ACLS is often just like a 1-day, or you can do an online set of modules and you just go in to show skills. That's what most people do, because who has time to sit in a classroom for all 8 hours? Oh, nursing students. Just kidding. Okay. Anyways, so those are some of the differences between the two, okay? And it's important that you know the scope of practice between those. So if you know that you're working with somebody that is only BLS, they're not ACLS, you know that that you're probably going to be the one in charge if you're ACLS, and you're going to delegate to them for doing possibly like rescue breaths with a bag valve mask and chest compressions, whereas you, the ACLS provider, is going to be doing more of the pharmacology management, assisting with airway, and all those kind of things. Okay. So it is important that you know the difference. So I know I keep harping on this, but BLS is the foundation and ACLS is like the scaffolding full structure that builds upon it. Okay. So, BLS, it provides those essential skills for saving lives. It's really important, such as deep CPR and defibrillation, but ACLS is going to build upon those things, okay? Now, defibrillation with an AED, we do shock in ACLS, but there's all sorts of different things of it. It's not just as easy as turning on a button and letting it think for you. You're now the computer, and now you have to think, and based off of what you can see on the screen, just determine when to shock or cardiovert, or what do you have to do? How many joules do we need to charge it up to? So you need to choose the electricity level. So there's a lot more involved with the ACLS. So some of those advanced skills, we're just going to kind of summarize a few of those things, kind of going forward, just some overall components, just so you understand what's included in the course. We are in modules 2 and 3. We're going to get really into the actual rhythm interpretation and medications, okay? And then we're going to go through those algorithms as well. But for the rest of this module, we're just going to kind of skim over the components of ACLS on a broad scope, okay? So again, advanced airway management. That might be an ET2, but it might be other things. Meds that we talked about, rhythm interpretation, synchronized cardioversion, those are the things. I know I keep repeating myself, but those are the main components of that are the advanced skills that require that advanced knowledge in ACLS. So another super important thing is the team dynamics. I know I already kind of mentioned this earlier, but this is not like a you by yourself kind of situation. You've activated that emergency response, and hopefully you have friends that have come to help that are competent and trained. Hopefully the code team is quick. So just remember, like, effective teamwork is so important for ACLS because everybody's got a job, and basically if you work together really well, the patient's going to have better outcomes. Each member of the team plays a very specific role. Often there's some of the roles are like team leader, there's a compressor, there's somebody that's in charge of airway, and there's somebody in charge of medication. So it's best if you have at least 4 people, but hopefully if you've ever been witness to a code, there's typically thousands of people. I know that's like a slight exaggeration, but tons of people show up to codes. And so it's helpful when you have more people, but it also can be confusing when there's a lot of people. Okay. So it's very important that communication is very clear. And when you are in a code situation, if you do not need to say something, don't say it. It's kind of like in law enforcement when there's a critical incident going on, they say stay off the radio because you don't want a whole lot of radio traffic where we can't hear the person that needs the help. It's kind of the same situation in a code. Like only typically it's the leader that is the main one talking. Everybody else, you're just kind of doing your task. Okay. If you are observing off the side of the room, especially like as a student, keep your voice very low, kind of whisper to the side if you have a question or that kind of thing. But you want to make sure that everybody that is part of the team can hear what is going on, what is being said, orders being given. So it's very important to maintain calm and quiet. And it's kind of the first time you're in a room where there is a code happening, you think it's going to be like how it is when you watch like Grey's Anatomy. We all know that Grey's Anatomy is completely fake, but sometimes it's very eerie how calm it is. And a calm code is the sign of competent, experienced people working that code. When it's like chaotic, that's probably because there's some people that are a little new, and that's okay. But hopefully the leader is experienced and everybody kind of follows the flow of the leader. So a little bit more about that. So the leader, yes, it is often the physician or an advanced practice provider, okay? It is normally the high-ranking person in the room per se as far as their scope of practice. But I will tell you that it will often start off as the nurse. The nurse is typically the leader, and when you go through ACLS, you have to be able to be the leader in a code, in a mega code simulation. You have to be the one that's telling people what to do. So you need to understand the role of a leader. Now, like I said, in the healthcare setting, in the real world, nurses will start, like the more experienced nurse in the room will most likely start off as the leader until the physician and code team arrives. But there's a good chance that an advanced practice provider or physician doesn't come for 5-10 minutes. They could be held up. Who knows what's going on? So you have to be able to assume that role of leading. Then obviously we know how important chest compressions are. There's the compressor. And honestly, what's best is to have at least 2 people in that role. And this, if you are not actively pumping on the chest and doing compressions, that if you're the other compressor, you are standing directly behind the compressor, ready to take over as soon as they say it. Okay. And this is if you have lots of staffing, and that's like, utopia with unicorns running around outside, but hopefully you have enough people. That is my favorite thing. When I was in the ER, my favorite thing to do, as soon as somebody coded, I would get on the intercom, and no matter where I worked, get on the intercom and say, any and all students, please report to shock room, insert number 3 at your earliest convenience. And they would all come running, and I'd be like, make a line. Because one of the best roles for a nursing student is to be the compressor, because you don't really have to think. You are all BLS trained. And yes, you are fully and perfectly competent, qualified, and trained to be a compressor. So when you guys go to clinicals here soon, if you are on a unit that has a code, I would encourage you to step up and step in and help relieve a nurse that's on that unit from doing the compressions so that they can focus on those med administrations and those other things, okay? Now, there's also the airway manager. They're basically going to stand at the head of the bed, okay? Hopefully you have respiratory therapy coming in, and they a lot of times will take over airway. But again, nurse has to be able to do all these things until somebody else arrives. So you're first going to start with that bag valve mask. Remember, it's that EC clamp to make a nice tight seal around the nose and the mouth so that you can be squeezing and giving those rescue breaths. And do y'all remember how in the ACLS, it's going to be like about every 6 to 8 seconds. And it doesn't seem like you're giving them enough breaths the first time you do that, but trust me, it's fine. We do not want to make them breathe more. They will become more acidotic, and that's not good. 6 to 8 a minute is good. Very slow and steady. So they stay at the head of the bed, like literally at the head, not on the side of the head. They should be at the head of the bed. So that's another thing. As soon as somebody codes, we often like unlock the bed, pull the bed away from the wall a little, lock the bed again so that the airway person can stand at the top of the bed. If the patient isn't intubated, the person coming in to intubate the patient needs to have that space. So we need to quickly move the bed away from the wall. So know that there's going to be lots of things moving around. People's going to be getting the code cart, and like there's lots of chaos in the very beginning. So like stay out of the way if you don't know what's going on. Like become one with the wall kind of thing. You are now the fly on the wall. Okay, so airway manager, they're in charge of that airway. They're going to make sure that the head chin tilt thing so that we have an open airway. They're going to be providing those rescue breaths. Hopefully RT comes. If it's a child, remember you want the sniffing position because they have that big old occiput in the back of their head. So a lot of times we will roll like a towel or a blanket or something up under the shoulders, and it kind of opens up their airway. This isn't a child, like a little person, like not like an 8-year-old, but more like a 2-year-old or even an infant. Okay. So these are some of the roles. Now, there's also roles, but these are the most important ones right here. Okay. So medication administrator, they need to give meds. They will also med will also be the shocker person. I know that's not like a real word, but the person that's dealing with the defibrillation and setting the things, making sure the pads get thrown on there and stuff. Hopefully, like I said, hopefully you have so many people present where everybody gets their own job. But just so you know, the medication person is typically also the person that's going to do the shocks, because the compressors focusing on that, airways focusing on that, and the leader really doesn't need to get involved. They need to be standing there and watching everything the whole time and making decisions and stuff like that. Now, the leader, if you don't have extra people, they also might be writing things down, like times when things get done, because you need to remember that for like how often you give epinephrine or how often we do pulse checks. But hopefully you have a separate person to document. Okay. Documentation is not a priority. The priority is getting the blood flow, but I guarantee you everybody's going to want it all documented. And so often a nurse will run into the room and grab those downtime form, the code blue chart. Go find one when you go on your units. They're great. They're extensive. They're kind of overwhelming if you've never filled one out. But once you fill one out, you're good. Anyways, and so then there's somebody that's documenting. That documenter is so important because they're watching the clock and they're going to remind people, hey, it's been like 6 minutes since we gave epinephrine. You want to give some more? Oh, yes, let's give some more. That's way too long, by the way. So anyways, there are some other roles other than these four, but those are kind of the big ones for ACLS, okay? So all these define, it's very important that you do define these roles and you understand if somebody says, they come in the room, I'm going to give meds, I'm going to do compressions, I've got the airway, you know what they're doing. And so you can make sure that everything's covered. If you're the leader and you notice that somebody says, I've got the airway, I've got the meds, well, I'll document. You are going to say, no, we need somebody to do compressions. You're not going to document, you're going to do compressions. So that's really important that the leader make sure that these things are covered. Okay. So closed loop communication, this is a term that ACLS and AHA pushes. Okay, so closed loop communications, kind of alluded to it before, but it is a technique used in ACLS to ensure that instructions are very clearly understood and the tasks are executed. Okay, it's a 3-step communication process that involves the sender giving an instruction, the receiver acknowledging the instruction, and then the sender confirming that that instruction has been carried out. Okay, so what does this look like? The leader's going to say, Jane, give 1 milligram of epinephrine now. Jane's going to say, I'm going to give 1 milligram of epinephrine now. She's going to go and pull it up, hook it up. Okay, she's pushing it. She goes, okay, I'm giving 1 milligram of epinephrine right now at 9:02 a.m. And she's saying it out loud. So the sender gives an order directly. You don't say somebody give it. You say you person. Hopefully you know their names. If you don't, then you need to say medication nurse. You got to do something. So you're directly giving them an order, because remember what I said, people become tunnel visioned. And so you've got to make sure that they know you want them to do whatever it is you're doing. They're going to acknowledge that they heard you by saying, okay, I'm going to blink, 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 whatever they said. And then when they're doing it, they're going to say it so that everybody in the room can hear, okay, it's being administered right now. The documenter knows the exact time that med was given, or, okay, stop compressions, whatever the instruction is. That is what closed loop communication is, okay? And this enhances patient safety. It makes things so much clearer. And it's the way that everything should be done when we're in the middle of ACLS. So, I already kind of talked about this, but there's the closed loop communication. It's also really important. I put this little video on here. Okay, I need you to shock. Okay, I'm going to be grabbing the paddles to do shocks now. Okay, you're putting it on. Okay, I'm about to shock. Clear, everybody clear. So that's the other important part of not everybody talking, because you want everybody to be here before we give shocks, right? So that they're not touching the bed, they're not touching the patient, all those kind of things, okay? Closed loop communication is so, so, so important. So now there's another part of ACLS is the primary assessment. So like when you walk into the room and you're doing the assessment in ACLS, the primary assessment involves basically a systemic evaluation, like an overall assessment of the patient's condition using the ABCDE method, okay? This approach helps healthcare providers and nurses quickly identify and address the immediate life-threatening issues, and it guides the subsequent interventions needed to stabilize the patient. So this kind of is the starting of those HS&Ts that we started before. So obviously, airway, breathing, circulation, that's part of BLS, but now we're also looking at disability and exposure, okay? You're going to identify and address these life-threatening issues immediately, if you can, and guide subsequent interventions. But this is only after we have initiated the actual BLS component of chest compressions and making sure oxygen is going, okay? So exposure, part of exposure is if they still have clothes on, we want to make sure, like if we don't know why their heart stopped, we need to see, do they have deficits for disability, like neurodeficits? Could it be a stroke? Exposure. Did they get shot? I don't know. Listen, rip your clothes off is basically what happens in the emergency department. But we need to see if you've been exposed to environmental toxins or if you've had trauma related. What is causing this? We can't just assume that it's because you had a heart attack. Okay. Like that's not the only reason why somebody's heart stops. So the D and the E is really important to make sure that we cover our basis. It's the beginning of covering our basis to figure out like what's going on with you. So airway ensure patency, yeah, because you need that kind of to be able to get oxygen places, right? Breathing, are they breathing or not? This is kind of part of the BLS, right? If they're not breathing, we need to start rescue breaths. Circulation, no pulse. We need to be doing that for them, right? Disability, you're assessing the neurological status. Were they alive or not? We can do so. Go back to health assessment. Remember, and those cranial nerves. Do they have a pupil reflex? Do they have a gag reflex? Is there tone in the anal sphincter? Big things that kind of tell you what's going on in the brain. And then you're also going to check for other injuries on the body. So you need to quickly look them over front and back. Okay, we don't just look on the front side. So this method is really, really important, and it ensures that you address all those critical aspects of patient care systematically. We want to make sure we kind of cover the big things, right, first. So kind of more on that advanced airway. So everybody always thinks about ET tubes, which is that bottom right picture over there where it's endotracheal, meaning that it goes basically, it's a breathing tube into your lungs. But the picture at the top right, it kind of looks funny, okay? That's an LMA. That actually doesn't go into the lungs. It actually kind of causes a seal like in the trachea. And that is, you will see like LMAs like in day surgeries and stuff like that. They don't do full intubation, but you will sometimes get EMS into an ER that will use like an LMA or like a king tube or something like that doesn't go all the way into the lungs. It's a little bit more safe so you don't like accidentally go into like the right stem bronchus. And we'll go over all this later. Don't remember that right now. But anyways, there are some other things other than ET tubes to help people. So that bottom left, see that yellow little tubey thing? That is called a nasal trumpet. That shoves up the nose, back down through the mouth. That helps like a floppy tongue from blocking the airway. It helps maintain that airway. The oral airway, which is the one in the middle, is kind of the same thing. Now, we'll go over this in our trauma lecture way in the and like towards like the latter end of the course. But like nasal trumpets, we would never stick that in your nose if you had facial trauma because we could intubate your brain, go through the cribriform plate, and that would not be a good thing. So there's oral airways. A lot of times when people are under the influence of drugs and or alcohol, they become very they can't maintain a patent airway. Their tongue becomes very floppy. They may have lots of oral secretions and stuff. And we will use these, EMS will use these just to kind of keep basically a tube in that area where the tongue could flop in the back of the throat and the upper part of the trachea. Just to kind of keep that airway open. So those are technically considered advanced airways as well, okay? So airway management, you're going to ensure oxygen ventilation. By the way, the oral airway, nasal trumpet, we can bag valve mask on top of that as well, okay? So sometimes we'll shove like a nasal trumpet in and then put the bag valve mask on and breathe for you because that's helping keep that open until we have somebody come in to intubate you. So they're critical for maintaining the vital organ function. And again, making sure that airways patent optimizes patient outcomes because we're able to get oxygen into their system. Go figure. So cardiac rhythm recognition, like I said, this module, we're not going to go into this specifically. That's going to be the next one. Okay. So it is imperative that you guys brush up on the basics of EKG interpretation because we're about to build upon it. You need to be able to identify, you need to be able to look at a monitor and say, uh-oh, that's VTAC, or uh-oh, that's VFib kind of thing. We need to be able to identify that pretty quickly, rapidly identify it, recognize what it is, and then do something about it, okay? That is a vital part of ACLS. So basically, I think you can surmise this, but the significance of being able to rapidly identify a lethal rhythm and intervene is that you're going to reduce delays in treating it, you might be able to treat it before the heart completely stops. Okay. It's going to improve patient outcomes. It's kind of like getting the AED on soon AED on scene as soon as possible, it enhances survival rates. The same thing. You are now your brain is now the AED looking at the heart rate monitor and saying, oh, shock advised. Okay, everybody, we need shock. Look, there's VTAC. That's kind of what it is. So you need to have those basic skills of being able to just look on the screen and be like, uh-oh, or as my kids would say, uh-oh, spaghetti-o. Okay, so now let's talk a little bit medications. There's a bunch, but on this page, there's some of the big ones. Okay, so our best friend, the thing that's given the most often, is epinephrine. Okay, so it is going to be given to hopefully start your heart up again, but it also has a vasopressor effect. Remember what vasopressors do to your blood pressure? We're pressing down, and so the blood pressure is going to go up, which helps us get the oxygen out. Okay, the blood and oxygen to where it needs to go. Antiarrhythmic, so these will maybe help fix a spazzy heart. Amiodarone, lidocaine. Lidocaine was one of those meds that we didn't use for a while, and it's resurfacing, and we're seeing it a lot more. More on that later. So bradycardia agents, so things to make your heart go faster. So atropine. So is atropine used a lot? It kind of comes and goes as well. So there's been years where it was like atropine left and right for like systemic, like symptomatic bradycardia, and then they stop using it. Now then they use it again, and they don't. But you still need to know about it. And then there's other drugs that we give, like mag sulfate, adenosine. You'll still see bicarb given. And so these are other drugs to treat other different things. Okay, but we're going to go more over this in Module 3. So in addition, so they're critical for, obviously, this is the same thing as what was on the last slide. So just kidding. We're just going to move on. Okay, so that's kind of it for Module 1. Okay, so I hope you learned a little bit, kind of an overarching of what ACLS is, a little review of BLS. Okay, there is going to be a quiz on Blackboard, open book, open note, not open partner, but not timed, basic quiz. Okay, just to kind of go over those fundamental pieces that I want to make sure that you know before we move on. If you have any questions, post them on the discussion board or send me an email. And if you have answers to them, answer your friends on the discussion board. Okay. And I will see and talk to all of you beautiful students later.